I also start introducing myself. Hi, everyone. Thanks again for having me today. I'm an assistant professor in biostatistics at Columbia, and prior to that, I was working at McLean Hospital and the Harvard Medical School Department of Psychiatry, and that's when this story starts, when I met Dr. Gur, working in the psychotic disorder division, and we started thinking about what is the role of the community around patients living with severe mental illness, and how can we augment current pharmacological solutions to help patients living with severe mental illness, in particular to improve quality of life, which opens big questions about measurement and about what are we measuring, what could be our behavioral targets. And this, of course, is very important, as we heard from Eric Daza before, to be able to develop valid causal models. So today, I would like to talk about this work that is also in collaboration with JP Onella on smartphone-based markers of social activity in bipolar and schizophrenia patients. So impaired social functioning is a hallmark of severe mental illness, in particular in schizophrenia and bipolar disorders. However, as many other complex behaviors are very hard to obtain from the patients directly. And this has really hampered the ability to develop behavioral treatments. In this study, we wanted to investigate what is the role of smartphone-derived measure of social network of these patients. And in particular, we wanted to evaluate whether we can extract these information about social network features of mobile communication in these patients and assess whether they are independent predictors of these three primary outcomes. First, the engagement of the patient in mobile communication, then self-report of digital activity, and self-report of loneliness perceptions. We also wanted to understand whether trying to identify important contacts for the patients further improved the predictability of these measures. So the bipolar longitudinal study is an amazing study that JP and Justin Baker and McLean Hospital established back in 2015, which has been following patients up to 4 years. So it's an amazing opportunity to be able to monitor these patients continuously over time, over multiple years. And I would like to remark, this is an initial pilot study, but I think as many of us have highlighted how the heterogeneity of these patients really lead us to think about N-of-1 studies. So we have 9 patients who are Android phone users, so for whom we could actually collect mobile data, who were followed between 1 month and 4 years. We spend a lot of time really trying to get the best quality data and the features that I just talked about. And we spent a lot of time visualizing this information. The primary outcomes that we consider were the count of outgoing calls and texts, the daily self-report of digital social activity and loneliness, ordinal variables, and our primary predictors were measures of connectedness captured by the reciprocity of calls and texts, as well as the number of unique people that daily were in contact with our patients, a measure of social network degree. It's very challenging to identify important contacts, and there is not a real solution yet. So far, we have selected important contacts based on relative intensity of count, length, and duration of outgoing calls and texts, as well as incoming, as well as the day in contact with those people. We use the thresholding and K-means clustering to identify these important contacts. We used 2 statistical analysis approaches to evaluate this association and the predictive ability of social network features, clustering and generalized linear mixed models. This is by no means really challenging to analyze this data. There's a huge problem of missing data that I have to unfortunately skip over, but there's a lot of methodology development that is needed here. And we analyzed the data, both considering all the contacts the patient is in relationship with, and also focusing only on the important contacts. And these are the main highlights of the results. When we consider all contacts the patient is involved with, we identify 3 clusters across our social activity, both active and passive, that we have for these patients. And notably, loneliness clusters separately from all the other features. Once we consider the important contacts, the number of clusters chosen reduces, all measures become more tight, and now loneliness clusters closely with social network degree. Similar results we find in the generalized linear mixed model analysis, where again we find that this feature of social network degree, if we select important contacts, is much more closely related to behavior as well as perceptions of social activity. So in summary, I would like to just first of all thank all my collaborators for guiding me through this fascinating journey. I really hope that this will help motivating future studies to really find actionable measures of social behavior where we can actually in practice safely intervene and also involving the community around the patients. Thank you for your listening, and also I would like to thank again all the collaborators and in my lab in McLean Hospital and Harvard. Thank you.